Hello and welcome to our presentation on tuberculosis. My name is Olivia and I'm joined by my group mates Haley, Lauren, and Hua. Tuberculosis has a long history. This bacteria is actually very old. It's been with humanity since ancient history through the Renaissance and into the modern era. In the 1800s, tuberculosis was a pandemic and even killed a quarter of the population in Europe. In 2021, there was 1.6 million deaths worldwide due to tuberculosis. So it's still a present active bacteria. There's also a long history of racism with beliefs surrounding who is most likely to become infected or spread infection of tuberculosis. However, nowadays we know that the bacteria does not discriminate and everyone is equally susceptible. Next slide, please. There's also a very interesting history around the societal influence that tuberculosis has had, specifically in Western society. There was kind of a morbid fascination around this disease. It was considered to be a very romantic way to die. There was many young people were affected, and they were kind of idolized or seen as very artistic, and it was a very dramatic, consumptive disease, as it was called. So there's a lot of art produced by people with tuberculosis, detailing their experiences and depicting them in art as they were, with very thin bodies from the lack of appetite that comes with the disease, bright red lips that would come as a result of fever, and big watery eyes that kind of um, also were associated with the disease, all of which are beauty standards that have endured into the modern era. So kind of interesting. Next slide, please.
Our patient history is a 78 years old woman with a history of moderate dementia, present with a persistent cough for 6 weeks, loss of appetite, and worsening functional decline. Family also report night sweats and recent confusion. Clients is hospitalized due to her symptom. The anatomy of this disease is so tuberculosis is caused by a bacterium called Mycobacterium tuberculosis, and it is usually start when someone inhaled the bacteria into their lung. So the bacteria then settle in the small air sacs of the lung where they can multiply or be contained by the immune system. If the immune system is strong, it may form a small lesion called granuloma, where the bacteria are contained but not eliminated. If the immune system cannot control the infections, then the bacteria then start to spread throughout the lung and other part of the bodies.
Okay, the pathophysiology of tuberculosis begins when the TB bacteria enters through the respiratory tract and reaches the lungs. The alveolar macrophages absorb the bacilli, and if the macrophages cannot suppress or kill them, the bacilli replicate inside macrophages and then burst out and infect new macrophages. This cycle continues, allowing the infection to expand. Lymphocytes then arrive at the infection site, triggering a cell-mediated immune response. Immune cells attempt to contain the bacteria and limit multiplication. During this stage, the host still remains asymptomatic. TB can either be cleared or enter latency inside the granulomas. For immune failure, if the host's immunity becomes impaired, containment then fails. The disease progresses rapidly to active TB, causing clinical symptoms. Next slide. As the granulomas mature, they begin to form and macrophages transform into specialized forms, including foamy macrophages. The granuloma center undergoes necrosis, meaning immune cells die. The necrotic core becomes caseous, a soft and cheese-like structure, reducing the structural integrity, which is typically rigid. Macrophages gather around this necrotic center. The foamy macrophages are due to the M. tuberculosis disrupting the host's lipid metabolism. The bacteria interfere with lipid uptake and release, causing lipids to accumulate inside. The macrophages become foam cells, which then help the bacteria survive within the granuloma. The caseous breakdown over time, the center softens and breaks down. This leads to formation of open lung cavities. Cavitation results in a high bacterial load, and bacteria escapes into the airway, causing active TB and enabling transmission. Dissemination occurs after cavitation, and persistent open cavities remain in the lungs. Bacteria can be spread throughout the lungs, GI tract, lymph nodes, and potentially to the spine, brain, meninges, and kidneys. Scar tissue begins to form around these damaged lung areas. Next slide. As you can see, on the right is a primary granuloma before infection, and the bottom middle granuloma is showing what latent TB looks like in the center of the granuloma. The left granuloma is representing the reactivated TB and shows the bacteria escaping because cavitation has occurred. Next slide. Regarding the stages, the latent stage begins when the bacteria lives but does not grow in the body, and the individual remains asymptomatic during this period, and it cannot spread from one person to another. The active TB is when the TB is active and grows inside the body. It is symptomatic at this point and can be spread from one person to another. Next slide.
Moving to the diagnostic process for tuberculosis. Diagnosis begins with a clinical examination when TB is suspected. During this exam, healthcare providers use a stethoscope to assess lung sounds, check for swollen lymph nodes, and evaluate the patient for persistent symptoms such as coughing, fever, night sweats, or unexplained weight loss. There are several testing options depending on the situation. The TB skin test is probably the most one that people are familiar with. You get a small injection under the skin of your forearm, and you have to come back in about 2 or 3 days to have results read. If there's a raised bump at the injection site, that indicates possible TB exposure. There are several testing options. There's also a blood test option, which works by drawing blood and testing for an immune response to TB bacteria. One advantage here is that you can get results without needing a follow-up visit, and it can help determine if someone has an active infection. For suspected active TB cases, chest x-rays are used. They can show characteristic patches, cavities, or other lung damage. And finally, sputum tests involve collecting mucus samples from coughing. These are tested rapidly to detect TB, and cultures can confirm the diagnosis and check for drug resistance, which is crucial for treatment planning. There's also some other specialized tests available, like urine tests, spinal fluid tests for TB meningitis, and procedures to collect sputum if someone can't produce it naturally. Next, please.
The treatments for active TBs are typically lasted 6 to 9 months, depending on the individual overall health and the severity of the disease. So whether any drug resistance is present or not. So the individual must take all prescribed medications exactly as ordered to fully kill the bacteria and prevent the development of the drug resistance. Um, so here are just the most common first line therapeutic medications here. So the treatments often provide through the direct observation therapy where a healthcare provider watch the patient take the medication, usually with food, to ensure doses are not missed. This is very important because if someone skip doses or stop treatment early, the bacteria can survive and become drug resistant. That means that an infection is no longer responding to the usual medicines, and the treatment then can take much longer, cost more, and harder on the body. And a little research I found is that higher income countries average cost for TB first line medications per patient is this is 2004 value, so it's like $14,000. And then for the second line defense medication, it can be up to 80,000 per patient. And as for the latent treatments, it's almost the same, but the goal here is just, to prevent TB from becoming active. So use almost the same medicines. And yeah.
The next aspect we want to address is how tuberculosis actually affects a person's daily life and their ability to participate in meaningful activities. This is where occupational therapy becomes relevant. TB has wide-ranging effects across all areas of occupation, starting with activities of daily living. Basic self-care tasks like bathing, grooming, and getting dressed become challenging due to reduced endurance and weakness. Patients often experience fatigue, shortness of breath, low energy, and dizziness. Additionally, loss of appetite and nausea from medication further complicate these routine tasks. When we look at instrumental ADLs and health management, things like meal preparation, home management, and community mobility are affected because fatigue and coughing spells cause weakness. There's also restricted access to public spaces because of the contagious nature of the disease, and many face financial strain due to inability to work. Rest and sleep is significantly disrupted. Night sweats, persistent coughing, and fever interfere with normal sleep cycles, which reduces the body's ability to rest and recover. For work and education, isolation requirements often mean lack of attendance, and even when present, patients struggle with depleted energy, endurance, and concentration, affecting job performance and academic participation. Leisure activities and social participation also suffer. The weakness and lack of energy make it difficult to engage in hobbies that require stamina or physical exertion. Socially, there's isolation from community members, family, peers, and patients often lack the energy to engage in meaningfully with others. Next slide, please.
Some of the occupational work that we would do with this client will change as they progress through treatment. So in the early phase, we know that there's going to be a lot of fatigue, and one of the main occupations we would focus on is rest and helping a patient recover their energy. We would do this both through restful activities, or the occupation of rest and sleep, but also through low energy expenditure activities such as reading, talking, or playing guessing games. In the later phases, as the client's strength is gradually improving, we would encourage group socialization with either other TB patients or their family when appropriate. We also would encourage cardiovascular endurance, such as like through the occupation of walking. This will help them recover future ADLs as well as singing, which we know that they like to do in their skilled nursing facility. Next slide. Thank you.
So after understanding how TB impacts daily life, we want to discuss how occupational therapy interventions can help address these challenges. First, energy conservation techniques are critical given the significant fatigue TB patients face. We would educate clients on pacing, helping them understand how to balance activity with rest throughout the day and break tasks into manageable segments. We might also recommend adaptive equipment like a shower chair to reduce the physical demand of bathing and other self-care activities. Second, symptom management strategies that focus on ensuring medication adherence and monitoring disease progression. This includes educating patients on taking their medications correctly and consistently, which is essential since TB treatment typically involves multiple medications over several months. Also, direct observation therapy, or DOT, is often used where a healthcare provider observes the patient taking their medication to ensure adherence and provide support. Finally, addressing the psychosocial impacts is equally important. TB can be very isolating due to its contagious nature and the stigma that sometimes surrounds it. We would engage or encourage patients to stay connected with family and friends through video calls, especially during periods of isolation. Additionally, connecting patients with TB support groups, whether that be virtually or in person, once appropriate. These can provide emotional support, shared experiences, and practical advice from others who understand what they're going through. These interventions work together to address not only the physical symptoms, but also the social and emotional well-being of individuals living with tuberculosis. Next, please. Here are our references. Thank you. We appreciate your time and attention during our tuberculosis presentation.